going to talk with a little. I've drawn from. I'm standing in today for Martin Johnson, who unfortunately can't be here, as he's the RCGP clinical champion for pain, and it's one of the key priorities for the Royal College of GPs for the next 3 years. One of their 4 key priorities. So I'm standing sort of on the shoulders of giants already. So him and Pete Moore give me a little bit of a background of what they think the problems are. So I'm going to put their words up, not mine. A little bit about chronic pain and how commissioners are now trying to sort of see this as a long-term condition. A little bit about what commissioning is as I see it. And then for you guys, what an ideal commissioner is going to look like. What an ideal specialist will look like to a commissioner. What you guys maybe could be to be of most use, as I see it. So this bit from... Does it come out from Martin did tell me he thought that he thought there'd be a lot of tomatoes thrown in this bit that he was going to do. So you know, don't shoot the messenger. So the key things he wanted me to highlight really is this issue really between the fact that there's still quite a blinkered approach in many areas of pain management. People doing things in a silo, doing what they've done and done very well, but not with an awareness of the wider field of what's going on in primary care, in areas where people are self-managing. Obviously, it's contrasted to some areas where people are really moving well, with a very wide multidisciplinary team. So there is contrast there. The other thing I wanted to highlight was about trying to develop a clear consensus. We're going to hear from Kathy about the pathways that have been worked up, but one of the things we're really missing in pain, I think, is a really clear consensus of how to diagnose problematic pain and how to work out what we're going to do for people, what's best evidence, and what are the outcome measures we're going to use to determine how well we're doing. GPs always get a bit of a bad name, don't they? They're a little bit simple, and do GPs really know how to manage pain? And probably more pertinently, can we teach them how to manage pain well? And what can we expect them to do that's going to be useful in this whole system of managing a population with chronic pain? Self-management. I've got 2 kids at home, and if I had got them trying to make pizzas, it wouldn't look like this, I can be sure. So we talk about self-management as though it's a kind of, we just do self-management, it's easy. But as we well know, actually, chaotic patients with really difficult lives, self-management's difficult, isn't it? So actually, getting people to do self-management is hard. But crucially, you've got to believe that it's worth it. Of course, the biopsychosocial approach, it's not new, is it? We've heard a lot about it over the last couple of days. But there is still an impression amongst people like Pete, who leads patients, patient groups, that we as the medical profession, allied health professionals, are still very focused on the bio, because we can do that, and that we still do the psychosocial bit badly. So those are their picking list of what they feel are the things that perhaps we are struggling with in pain medicine at the moment. So the difference in a blinkered silo approach and a widespread MDT approach, the lack of consensus, the poor education for GPs and for the general public. So Liam Donaldson at the Pain Summit, the thing that stuck in my mind was when he said, we need to make pain a household disease, a household condition. And knowing how much of it there is out there, it's amazing that it isn't already. How do we put the patient at the centre and empower them to live with it and self-manage their condition? And how do we get across this biopsychosocial approach across all of the teams that are involved in pain management, from primary care right the way through to tertiary care? I thought I'd feedback a little bit on this pain. Some of it I've alluded to already. It was it's had a lot of airtime. Richard's talked about it a few times over the conference. And I think it was quite a seminal moment, really, because it sort of marked, for me, a bit of a political recognition that actually chronic pain, pain management, it needs to be up there on the political agenda, and it's important. It's important to people, it's important to voters. A lot of voters live with chronic pain, so it's becoming more and more important to politicians and political groups. And in this event, there were workshops on education, public health and commissioning. There is a recognition that the majority of pain is going to be in the community and is going to be based around people self-managing, and we've got to recognise that. And there was these opportunities thrown out there of things that we can utilise to try and get this sort of message across. So, the frameworks like NICE, the quality outcome framework for GPs, the CQC registration that all of primary care has to go through now. The joint strategic needs assessment is going to become a really crucial aspect. I think people last night heard a little bit about a new structure of how local authorities are going to work with health and well-being boards that arch across both health and social care. And they're going to be informed, they're going to be using the joint strategic needs assessment for their population, an annual report that's produced to try and help them prioritise what's important. So we need to get in there and we need to get people asking questions about pain in the joint strategic needs assessment. And of course, we listen to the patients and hear what they say as well. The Patient Association report, I'm sure many of you have read this from a couple of years ago. Some of the things they highlight to us that chronic pain is a disease in its own right. That's what they're telling us. They want to see a clear care pathway for pain services. They want to know that they're going to get the same treatment across the board with good standardised information for them. They're telling us that their GPs don't know about this and they need education. But also they really value having pain specialists. They don't just want to be pushed out into a world where there aren't pain specialists. So, also, patients don't always do what we think they're going to do. There's a lot of patients get very frightened, don't adhere to the medicines. We give them out, actually, if they don't adhere to them. And they want further signposting towards services. So, when I'm sort of finding myself in a position of being someone who's interested in pain and trying to look at how can you shoehorn, get pain on the agenda, one of the key things I think is this idea that chronic pain is one of the long-term conditions. There's an NSF for long-term conditions. There's a strategy in most PCTs for how you organise your long-term conditions. Diabetes, heart failure, chronic liver disease, asthma, COPD. We need to be making sure that everyone appreciates that chronic pain is one of those long-term conditions. And actually, if you look at the prevalence of chronic pain, even if you take not just the sort of the headline figures of 1 in 7, 20% of the population have chronic pain, if you take the sort of epidemiological figures of problematic pain, so pain that actually is a major important part of someone's life, and the figure that I kind of work with is around about 7%, which comes out it seems to be coming out a lot, and you multiply that with the effect it has on their quality of life, it is the biggest impact long-term condition. So, I guess two crucial people who are pushing how we manage long-term conditions. Chris Ham, who's now the CEO of the King's Fund. He's an economist and a management specialist professor from Leicester University. And Sir John Oldham, who's a GP, but he's a national clinical lead for quality and productivity. And Chris Ham, probably 2 years ago now actually, produced this list of 10 key things in chronic disease management, in managing a long-term condition. Universal coverage, free at the point of use. Our NHS is still just about free at the point of use, I think. Prevention being key. Self-management. Prioritising primary care pathways. Stratifying according to risk. Really good integration between primary and secondary care. Good information flow, our computer systems that talk to each other and link up. It's amazing, isn't it, in the kind of internet world now that hospital systems still don't talk directly to GP systems. And that we have an integrated approach to care, a care planning approach. And that all this is tied up in an overarching strategy that people like us, the British Pain Society, should be directing. And I highlight in red the three that Sir John Oldham is now really, sort of for the last 18 months, has been taking a roadshow around the country, really, around primary care and commissioning organisations, as the three that he sees as absolutely key to changing the landscape, of the economic landscape in the country. And in fact, he believes that if we don't do this, the country will be bust within 10 years. I mean, he's absolutely adamant on this. So, getting people self-managing well, identifying risk. You heard Nadine talk a little bit earlier about how the Arthritis Research Centre in Kiel is leading ways of stratifying people's risk early on, And we can do this in all chronic disease areas, but we can do it in pain. And then having a sort of care planning approach to how we manage people. And again, patients' views on this, the whole idea of the government, but it documenting sort of no decision about me without me, it is a patient-led strategy. They listen to what matters to people because it wins them votes. When they were putting out their information from the patient voices, they talked about of their 9 key points. Their biggest thing they found patients want integrated care. They want seamless integrated care across the system. That's what really matters to them. So I was going to move on to talk a little bit about how we do this care planning, this context of care planning, really. And I think what, again, is coming out in the commissioning world is that we can't treat long-term conditions in isolation. This is a little bit of a busy slide, but it's taken from data that's just recently been produced in Scotland, where they looked at 1.7 million people. So I don't quite know the population of Scotland. I don't know if that's everybody in Scotland, but it must be a significant proportion of them. And they looked at people in that population that have long-term conditions. And I just highlight for you those painful conditions here. And what this slide is demonstrating is the proportion of people that have, so 13% of people only have a painful condition as their long-term condition. Okay. 21% of people have pain and another long-term condition. Another 21% have pain and 2 other. And actually, the majority of people that live with a painful condition have at least 3 other long-term conditions. And you can see what the long-term conditions they're talking about. So heart failure, cardiovascular disease, diabetes, chronic respiratory disease, cancer, epilepsy, and mental health problems. So actually, when we're taking people, we need to be thinking about how we can manage pain alongside other long-term conditions. And this other slide that I pulled from their slide set with permission, it is, again, just highlights that it's busy again. I'll take you through this a little bit. So the top line here, the figures here, are actually indicating the percentage of the whole population that has this long-term condition. And you can see here, 7.2% have what they define as a problematic painful condition, what they think fits into being what should be managed as a long-term condition. And you compare that to COPD. It's twice as many people with COPD, and look at how much emphasis we put on that. It outshines all of the others apart from hypertension. And if you look down here, what these bubbles are applying to is it shows how many people with these conditions have pain as well. So actually, the size of the bubble indicates the number of people. So sure, as probably expected, most people, the most common one that they have is hypertension. But actually, probably the next most common that people with long-term conditions have is a painful condition. So it's there. Do you know what I mean? But it's just being ignored. And that's my challenge to you guys. To all of us is actually there's a mission here to get this up the agenda, because it is important, and it's just not being recognised, and it's not being treated and planned for. Now this is a bit of a challenge, isn't it? What's commissioning? And it's evolving all the time. I can tell you, it's not static, and people that feel strongly about it will shape what commissioning looks like. My best stab at it at the moment, as I stand here today, and it may be different next month, is that I think the key thing is that it's value-based. And when people who don't have an expert opinion in every area, you can't possibly make financial decisions or planning decisions or commission decisions about only the areas you know something about. So what you need is you need to be able to make a value judgment. You need to be able to work out what areas of medicine are going to produce really good health gain for a certain cost that you spend on it. And I'm going to come to that a little bit more in a second. It's needs-based, so in chronic pain, we need to be looking at identifying the need out there of the problematic pain and matching that up. It needs to be clinically led, as I've said, and that's across the whole board. It's not just GPs, it's specialists, clinicians, patients working together. And that'll be a mixture of evidence-based but also experience. You know, there isn't an evidence base out there for everything, so we have to take the evidence base and combine it with the collective experience and the values that we all share. And you know, it's an economic thing as well, isn't it? You know, at the end of the day, the politicians have to make the books balance, and that's what they're mostly, you know, the oneless scenario, I guess, of a fully engaged population versus a disengaged population, have a huge range of economic consequences for the country. So there's a massive economic gain here. And of course, self-management is perceived as being very cheap. You know, so there's a temptation to want to drive everyone towards self-management. I guess we've got an obligation to make sure that actually self-management is good value as well. So, you know, it comes together really. So just to expand a little bit on what I think value is, this is as mathematical as this talk's going to get, I can assure you. You know, value is really the health outcomes that you get divided by the cost it takes to get those. And you know, the outcomes is tricky, isn't it? You know, what outcomes? You know, what is it that matters? What are the outcomes that value? And that's where I think we have to get together and form a consensus. And it may be different in every area, in different you know, communities. So, you know, people are trying to develop tools where you pull in the evidence base that's available, and then you debate with the patients, with the GPs, with the specialists, with other groups I could go on, as to what those outcomes look like, and what matters to you. You know. And then, you know, there's gaps. You know, we're going to have research. It's going to come in to fill in some of these gaps, but we're never going to fill them all. I'm going to just very quickly touch on something that we're doing. I'm out for time here in Sheffield. Just to you know, look at maybe some of the things that might fill in some of these gaps. And you know, this is looking about a range of things that can potentially be done in managing a population with chronic pain. We put a bid in, it was a fantastic way of winning £50,000 actually. We went to a sort of a day's event with the SHA, and they had a kind of Dragon's Den kind of thing, and we competed against a few other teams, and at the end they said, right, here's a cheque, £50,000. And what we wanted to do was to look at using health trainers, so very inexperienced people just trained up in motivational interviewing, signposting, and aware of all the facilities that are available in the health, in the sort of health arena, in the social arena, in the community, that might be useful in managing and helping pain. And it was sort of based around a sort of a behavioural change model. You know, primarily patient-led goal setting, signposting, and then following up through a sort of series of follow-through. And just, you know, it's ongoing. It's going to be assessed by SHA, the School for Health Social Research in Sheffield. And the first 100 patients, just very early results back, you know, that for these people selected from primary care, where GPs have said, well, actually, I think this is someone who's struggling a bit. They're not bad enough to go to the pain clinic, but, you know, actually they're in this in-between stage, you know, where actually there isn't very much available at the moment. And this is proving very effective, you know. In the sort of questionnaire response from the patients, a 48% improvement in the WHO wellbeing scores, and a 34% improvement in general health. And this is using, you know, very, very, really peer support. So it kind of just, it represents, you know, some of the possibilities that are there. That certainly doesn't replace the need that people have in extreme, you know, extreme apex of the triangle. But actually, perhaps it's some of the things we could be doing a bit more imaginative look towards the self-managing scale. And some of the qualitative stuff that's coming back, you know, patients expressing change in terms of adapting and coping, and they talk about reinventing their positive feelings. That was a phrase that came out from some of the work, and you know, coping with the limitations, and as a result taking less medication. Again, sort of feeding into the sort of commissioning arguments about where, you know, we can do things a bit differently and make an economic difference. So just to finish with, I'm going to give you my view of what I think the ideal pain specialist will look like towards a commissioner like myself or others at in the CCGs. Maybe this. That's probably for the ladies on the boards. Was it like this? I don't know. George Galloway, is quite outspoken. He's been on, I think he was on Big Brother, wasn't he? But he's not been afraid to sort of stand up for the small man. A campaign against war, and he's recently run a seat in Bradford, isn't he, in the Respect Party? Or does it look like this? Aung San Suu Kyi, who has come out of 5 years of house arrest in Burma, been persecuted for most of her life because she stood up for what she believed in. But we need you to be champions. So I think people need to be coming out of a blinkered approach, and they need to be able to think on a population level. They need to be able to think for a group, for a whole society. What's the needs, from the simplest needs up to the most complex needs of our population of people with pain. Need to be able to recognise these areas of integration with other specialties, the multi-morbidity that we know are out there, and be able to make plans that can include all these multi-morbidities. Be able to identify what the outcome measures are and be used to capturing them as often as we can. Be able to stratify needs. We need help from the specialists to help GPs, people at early contact people, identify how we're going to stratify these needs. Encouraging the patient voice. The patient voice is going to be the currency of commissioning, really, isn't it? And I think, above all, campaigns for recognition of pain in society. How are we going to make chronic pain, persistent pain, problematic pain a household condition? My last slide then. So I think the future is that we need to campaign for pain to be part of joint strategic needs assessments. We need care to be tailored towards care tailored towards needs. So the stratified approach. We need to be thinking about chronic pain as a long-term condition. We need to focus on value base and how we can demonstrate that in our specialty. And we're going to need to continually evolve as new research and new evidence feeds in.